Welcome to this deep dive into medial thigh lifts.
Crucial topic for the FRCS plastic surgery exam.
We'll cover essential anatomy and patient evaluation
Techniques.
and complications to give you the knowledge you need.
Let's get started with the anatomy.
Right.
The medial thigh's outer layer is pretty thin.
Right.
It consists of the epidermis and the dermis.
Okay.
Underneath that, you've got two fat layers that are separated by the superficial fascial system, or SFS.
Okay.
Deeper still is the callus fascia.
Okay.
Now, that's a really key structure.
What makes the callus fascia so important for this procedure?
Well, its attachments are really key.
Okay.
It attaches to the pelvic bones, or the ischiopubic rami.
Uh-huh.
It attaches to the abdominal wall's scarpus fascia
Mm-hmm.
and to the back of the urogenital diaphragm.
Okay.
It's particularly strong where the perineum meets the medial thigh,
Right.
forming that perineal thigh crease.
Yeah.
A very crucial landmark.
How do surgeons locate callus fascia during surgery?
You dissect at the adductor muscle's origin on the ischiopubic ramus
Uh-huh.
and retract the vulvar skin and fat medially.
Okay.
The callus fascia becomes visible then
Yeah.
as the deepest, most lateral layer of
Right.
the vulvar soft tissue.
Okay.
Moving laterally,
Yeah.
we encounter the femoral triangle.
Right.
And what should surgeons be aware of in this area?
Well, that's a very important area.
Yeah.
What should we know about it?
It contains vital blood vessels, nerves, and lymphatics.
Right.
So meticulous dissection is really crucial here
Okay.
to avoid any kind of complications.
Things like
Vascular injury, nerve damage, or lymphatic disruption.
all very bad things.
Yeah.
Let's move on to patient evaluation.
Okay.
What are the initial steps?
The history and physical are very important.
Okay.
You want to assess skin quality.
Uh-huh.
You want to identify the degree and location of any ptosis
Right.
and map the distribution of subcutaneous fat, not just in the medial thigh,
Okay.
but also laterally around the trochanter and the
Right.
lower torso.
Okay.
So really get a good feel for the whole area.
So it's very important to see where the fat is.
Yeah.
If a patient has significant fat deposits
Uh-huh.
or lipodystrophy, what then?
Well, liposuction is
Yeah.
recommended
Okay.
at least 3 months before
Okay.
the thigh lift
Okay.
to allow those tissues to settle.
Yeah.
And that'll give you a more accurate picture
Yeah.
of the skin laxity.
Okay. So liposuction first, potentially.
Potentially,
Okay.
depending on how much.
What other conditions need dressing before a thigh lift?
Abdominal or pubic laxity.
Okay.
That should be corrected first.
Got it.
And then for those massive weight loss patients,
Uh-huh.
a staged approach is best.
What does that mean?
Lower body lift first,
Okay.
followed by the thigh lift.
So 2 stages.
Yes,
Okay.
for massive weight loss.
Now there's a classification system
Mm-hmm.
for medial thigh deformities.
Uh-huh.
Can you explain that?
Yeah, so there are 5 types.
5.
Yeah.
Okay.
Type I, with lipodystrophy but no skin laxity.
Uh-huh.
Just address that with liposuction.
Okay.
Type 2, with leukodystrophy
Uh-huh.
and laxity in the upper thigh.
Yeah.
That's liposuction and horizontal skin excision.
Okay.
So those are the first 2.
What about the other types?
Type 3 involves laxity beyond the upper thigh.
Okay.
So you'll need both horizontal and vertical excision
Right.
along with liposuction.
Okay.
Type 4, with laxity along the entire thigh,
Uh-huh.
requires a longer vertical resection.
Okay.
And finally, type V, the most severe,
Yeah.
involves aggressive liposuction,
Uh-huh.
followed by a delayed excisional lift.
So that one's a 2-stage as well. Yeah. Yeah.
2-stage, but for a different reason
Right.
than the massive weight loss.
Okay. So 5 different types.
Yes.
Let's move on to operative techniques.
Okay.
Starting with the classic medial thigh lift
Uh-huh.
with transverse skin excision.
Yes.
What are the key points
Okay, so
for preoperative markings?
the patient stands with their knees apart
Okay.
for an accurate assessment.
Uh-huh.
Mark the areas for liposuction,
Okay.
the femoral triangle,
Uh-huh.
as a reminder to avoid it,
Right.
and the incision line
Okay.
along the medial thigh crease
Mhm.
from the pubic tubercle to the perineal thigh crease.
Okay. So lots of markings.
Yeah.
How's the amount of excess skin to be removed determined?
A pinch test,
Okay.
typically a 5-7 centimeter resection,
Uh-huh.
but anchoring the SFS to callus fascia
Okay.
can gain an additional 3 to 5 centimeters
Okay.
of lift.
And if the laxity extends beyond the upper thigh?
You'll need to add a vertical ellipse
Okay.
to create a T-shaped incision
Got it.
for a more extensive resection.
Now let's get into the technique itself.
Okay.
What is the technique?
So the patient is supine, frog leg, without stirrups.
Okay.
The incision follows the markings. The inferior flap is carefully dissected, 2-3 centimeters, beyond the planned excision, avoiding damage to that underlying muscular fascia.
Very important.
Yes.
What's the role of callus fascia in the procedure?
So you identify the callus fascia
Yeah.
near the adductor muscle origins.
Okay.
Retracting the vulvar tissues can help you visualize it.
Okay.
Then the SFS of the medial thigh skin is anchored to callus fascia.
Okay.
And you want to remember to preserve the soft tissue between the mons pubis and the femoral triangle to prevent lymphedema.
So very important.
Yes.
So what follows that?
A drain is placed.
Okay.
And the wound is closed in layers with separate closure, the SFS, the deep dermis, and finally the subcuticular layer.
Okay, so multiple layers.
Yes.
Let's talk about the modified medial thigh lift.
Okay.
For those massive weight loss patients.
Yeah.
How does this approach differ from the classic technique?
It targets the correction of horizontal laxity.
Okay.
So common in these patients. So the emphasis is on a longitudinal medial thigh incision, whilst the transverse crease incision is minimized.
And is anchoring to callus fascia required?
No, it's not necessary.
Okay.
The focus is on redraping and tightening
Okay.
without relying on the callus fascia.
What about the markings?
Markings are similar to the classic,
Okay.
but the focus is on determining the line of closure
Uh-huh.
to ensure minimal scar visibility.
Okay.
And a pinch test helps you assess how much you can remove
Okay.
anteriorly and posteriorly.
So how do you do the modified medial thigh lift?
Positioning is supine, frog leg.
Okay.
Liposuction around the knees is performed either during or 3 months prior.
Okay.
The anterior incision is made first. Dissection proceeds down to that deep fat.
Okay.
You want to carefully preserve the saphenous vein.
Right.
Why is it important to preserve the saphenous vein?
I imagine it's very important.
Injury to it can lead to prolonged leg swelling due to disruption of the venous drainage.
Okay, so very important.
Yes.
How is the resection performed?
The vertical resection is done first.
Okay.
And it's safest to do it segmentally.
Okay.
This ensures appropriate tension in each area and minimizes edema, allowing for a good closure.
So you do the vertical resection first?
Yes.
And then?
Then the medial crease resection, performing it after the vertical, prevents excess tension on the horizontal closure.
So very specific order.
Yes.
Okay.
Very good.
What are the final steps?
Of the modified medial thigh lift. Drains are placed.
Okay.
The wound is closed in layers,
Uh-huh.
approximating the SFS, deep dermis, and subcuticular layers.
Okay.
And finally, a compression garment is applied for support
Makes sense.
and to minimize swelling.
Now let's touch on the fasciofascial suspension technique.
Okay.
How does this differ from the other two techniques?
This technique, proposed by Candiani, uses the strength of the gracilis and adductor longus fascia for support instead of anchoring to callus fascia.
Okay.
So how is the lift achieved in this technique?
I'm interested to find out.
By overlapping and closing this fascia, you create a fascial support structure, allowing the skin and fat to be resected and closed under minimal tension.
Okay.
So you're using the fascia to support the tissues.
Moving on, what are the potential complications?
Okay. So you can have skin irregularity.
Right.
You can get hypertrophic scars. You can get buttock flattening from wound tension, vulvar distortion, lymphedema, and recurrence of the thyptosis.
Okay, so lots of things can go wrong.
Yeah. It's important to be aware of the potential complications.
Let's discuss post-operative care.
Okay.
What are the important aspects?
So you want to consider perioperative anticoagulation to prevent blood clots. You also want to use compression garments for 2-4 weeks. Early ambulation is very important.
Right.
And drains are usually removed in 5-7 days.
5 to 7 days.
Yes.
What about wound care and activity restrictions?
Daily dressing changes are necessary.
Okay.
Driving's restricted for 1 to 2 weeks. And you want to restrict exercise for 6 weeks to allow for adequate healing.
So pretty much everything's restricted.
For a period of time.
For a period of time.
Yeah.
To ensure the best result.
Exactly.
Okay, great.
So that covers postoperative care.
That's good.
For medial thigh lifts. So let's go back to the classic medial thigh lift.
Okay.
And break down the technique in a bit more detail.
Mastering this common procedure is very important.
Yes, very important for any plastic surgery resident.
Indeed.
First, let's revisit those preoperative markings.
Okay.
The patient should stand with their knees apart so you can accurately assess the excess skin and fat under the influence of gravity.
So the standing position gives us the most realistic view.
Precisely.
Okay.
Mark those areas for liposuction.
Okay.
And outline the femoral triangle as a visual reminder to avoid that area during dissection.
What are the consequences if you accidentally go into that area?
Well, it houses those vital structures. Like the femoral artery, vein, and nerve.
Yeah.
Damage there could lead to serious complications.
Like?
Bleeding, nerve injury, or lymphatic disruption.
Oh, very bad.
Yes, so marking it is a crucial safety precaution.
And the incision line?
Is marked along the medial thigh crease, from the pubic tubercle to the perineal thigh crease.
Why is this location chosen?
It offers excellent camouflage for the scar, making it less conspicuous.
Yeah.
Historically, the incision extended further back to the buttock crease, requiring the patient to be prone.
So the incision has changed over time?
Yes. Extending the incision posteriorly was found to add unnecessary complexity without improving outcomes. So the current approach, ending at the perineal thigh crease, is more streamlined. Allows the whole procedure to be done supine.
Okay, good. Once the incision line's marked, how do we determine the excess skin to be removed?
A pinch test. On average, a 5 to 7 centimeter resection is standard. But remember that anchoring the SFS to callus fascia can provide an additional 3 to 5 centimeters of lift.
So that anchoring really maximizes the skin tightness.
Absolutely. And if the patient has laxity beyond the upper third of the medial thigh, a vertical ellipse is added to that transverse incision, creating a T-shape for a more extensive resection.
All right, walk us through the technique now.
The patient is supine, legs in that frog leg position. Stirrups aren't necessary because the incision ends at the perineal crease. The incision follows the markings, starting at the pubic tubercle, extending laterally along the border of the mons. What about the flap dissection?
Very important part of the procedure.
The inferior flap is carefully dissected 2 to 3 centimeters beyond the planned skin excision. It's very important to avoid violating the underlying muscular fascia.
And why is that?
This can lead to contour irregularities and compromise that support structure. So precision is key during this dissection. Now let's focus on the callus fascia.
Seems to be a recurring theme in medial thigh lifts.
Yes, very important. First, it needs to be accurately identified. It's located near the origin of the adductor muscles on the ischiopubic ramus. Retracting the skin and fat of the vulva medially can improve your visualization. Callus fascia appears as that deepest and most lateral aspect of the vulvar soft tissue.
Once it's identified, what do we do?
The SFS of the medial thigh skin is anchored to the callus fascia. This is critical for providing that support and enhancing that lifting effect, resulting in a much smoother contour.
Any precautions to take?
Preserving the soft tissue between the mons pubis and the femoral triangle, that's vital.
Why?
This bridge contains lymphatics, and disrupting it can increase the risk of lymphedema. So delicate balance between lift and lymphatic drainage. Once the SFS is anchored, a drain is placed, and the wound is closed in layers, approximating the SFS, deep dermis, and that subcuticular layer.
So again, multiple layers. That concludes our deep dive into the classic medial thigh lift. Now let's shift gears to the modified technique. For massive weight loss patients. They present unique challenges.
You're right.
What are the key differences between the two?
The modified technique addresses that significant horizontal skin laxity that you see in these patients. Yeah. Primarily, it utilizes a longitudinal medial thigh incision.
So different incision placement.
Yes. Okay. The longitudinal incision allows for more effective removal of the excess horizontal skin, creating a smoother, more aesthetically pleasing contour.
And that transverse crease incision?
It's minimized.
Okay.
Primarily used for removing any dog ears. Or cutaneous deformities. Another key distinction is that anchoring to collatella fascia is not necessary.
Why is that?
Well, these patients have often lost substantial subcutaneous fat and volume. So the skin can be effectively redraped and tightened without it.
What about the preoperative markings?
Similar to the classic approach, the patient stands with legs apart for accurate assessment of the laxity and the planned line of closure.
And determining that line of closure is crucial.
Absolutely. We want that scar to be as inconspicuous as possible. Ideally hidden medially in the thigh. A pinch test is performed to estimate the amount of skin and fat that can be safely removed, both anteriorly and posteriorly.
And then the incision lines are marked.
Precisely. Now, the surgical technique itself.
Walk us through the steps.
Positioning is the same. Supine with legs in that frog leg position. Liposuction around the knees. Often performed either during the procedure or as a separate stage 3 months prior.
What influences the timing?
The extent of lipodystrophy and surgeon preference. Once liposuction is complete, what's next?
I'm eager to find out.
The anterior incision is made. And the dissection proceeds down to that deep fat. The skin and fat to be excised are elevated as you move towards that planned posterior incision.
Any critical structures to be aware of?
The saphenous vein. Crucial to preserve that vein.
What happens if you injure it?
Can cause prolonged swelling and edema. Once you reach that posterior incision line, you can begin the resection.
And how's the resection performed?
The vertical resection's done first and safest to do it segmentally. Ensures appropriate tension and minimizes edema. What comes after that?
The vertical resection.
The medial crease resection. Performing it after the vertical prevents excess tension on that horizontal closure.
So the sequence is important.
Exactly. Drains are placed. The wounds closed in layers, approximating the SFS, deep dermis, subcuticular layers. Finally, a compression garment is applied for support and to minimize swelling. That covers the modified medial thigh lift.
Now let's touch upon the fasciofascial suspension technique.
This technique, proposed by Candiani, is an alternative to the other two techniques.
What's the underlying principle?
Instead of anchoring to callus fascia, it utilizes the strength of the gracilis and adductor longus fascia to provide support and lift.
So it's leveraging existing structures.
Exactly. It starts with a transverse incision made below the inguinal crease, lower than the other two techniques. That provides access to the fascia.
Once the incision is made.
The skin and fat are undermined down to that fascia. Then the fascia is overlapped and closed, essentially taking up the slack.
So the fascial closure provides the lift.
Yes.
What happens next?
The skin and fat are resected and closed under minimal tension. Seems like an interesting alternative.
It does.
It has its advantages and disadvantages.
Now let's move on to complications. Understanding these is essential for good patient care.
Yes.
What are some common ones?
Skin irregularities and depressions. You can get hypertrophic scars. What else?
What factors can lead to those hypertrophic scars?
Patient factors like genetics and skin type. Wound tension, infection, and poor wound care can all increase the risk.
Are there any complications specific to the buttock?
Yes. Flattening of the buttocks can occur if there's excessive tension from the closure.
And how can you minimize this?
Careful planning of the incision and the resection, along with meticulous closure techniques.
So really good technique.
Yes, very important.
What about complications related to the vulva?
Distortion of the vulva can occur.
Okay.
With extensive skin resection or improper handling.
Right.
Of the tissues in that area. So again, understanding the anatomy, meticulous surgical technique, very important.
What about lymphatic complications?
Lymphedema is a concern.
Right.
If those channels are disrupted. Preserving those vessels is crucial.
Okay.
Avoiding excessive tissue manipulation and ensuring adequate lymphatic drainage post-operatively can also help.
Okay.
And could the thigh ptosis recur?
After a thigh lift.
Yes, recurrence is possible if those underlying causes aren't addressed.
Such as?
Aging and weight fluctuations, patient education, and long-term follow-up are essential.
Now let's move on to post-operative care.
Okay.
What are the key things?
Perioperative anticoagulation should be considered. To reduce the risk of DVT, compression garments are another essential part. They provide support, reduce swelling, and promote contouring.
How long should they be worn for?
Typically for 2 to 4 weeks.
Okay.
Postoperatively.
And ambulation.
Early ambulation is also encouraged. Improves circulation and prevents DVT.
When are drains removed?
Usually in 5 to 7 days.
5 to 7 days.
Yes.
Okay.
Daily dressing changes are important.
Okay.
To keep the wounds clean.
Yeah.
And to monitor for any signs of infection.
And driving.
Restricted for 1 to 2 weeks.
Okay.
Or until the patient feels comfortable.
Okay.
And what about exercise?
Important to know when you can get back to normal.
Strenuous exercise should be avoided for at least 6 weeks to allow for adequate healing.
That's a thorough review of postoperative care?
Yes.
For medial thigh lifts?
Yes, that covers it.
Now, let's go through some potential exam-style questions.
Sure.
Help you apply your knowledge.
Yeah.
Identify any gaps.
Good idea.
Okay, here's a scenario.
Okay.
A patient presents with significant lipodystrophy.
Okay.
And moderate skin laxity, extending beyond the upper third of the thigh.
Right.
What type of medial thigh deformity is this?
So that would be...
And what surgical approach?
A type 3 medial thigh deformity.
Okay.
The recommended approach would be liposuction, combined with both horizontal and vertical skin excision.
Okay, good.
To address both the lipodystrophy and the skin laxity.
Another scenario.
Okay.
A patient has severe medial thigh skin laxity and lipodystrophy.
Okay.
What would be the management strategy?
Given the severity,
a
2-stage approach is recommended.
Okay.
The first stage would involve aggressive liposuction to reduce that subcutaneous fat volume.
Makes sense.
Allows for better tissue assessment before the second stage.
What would that involve?
After adequate tissue settling, typically a few months after the liposuction.
Okay.
The second stage would be an excisional medial thigh lift.
Okay.
To address that remaining skin laxity.
Okay, one more.
Okay.
During a classic medial thigh lift, you're dissecting near the origin of the adductor muscles.
Right.
Which important fascial layer should you carefully identify and preserve?
That would be the callus fascia.
Right. And to reiterate,
yes.
Why is it so crucial to avoid violating that muscular fascia during the flap dissection?
Violating the muscular fascia disrupts the support structure of the thigh and can lead to those contour irregularities that we talked about.
Okay, excellent.
So very important.
Now let's shift to post-operative care.
Okay.
What type of garment is typically recommended after a medial thigh lift?
A compression garment.
Oh, for how long?
Is key. It helps reduce swelling, support the tissues, promote optimal contouring.
Okay.
Patients usually wear it for 2 to 4 weeks after the procedure.
Okay, and activity level.
Okay.
When can patients typically resume driving and exercise?
Driving is generally restricted for 1 to 2 weeks.
Okay.
Or until the patient feels comfortable.
Yeah.
And has regained enough mobility.
Right.
Strenuous exercise should be avoided for at least 6 weeks.
Okay.
To allow for adequate healing.
Okay, great.
And minimize the risk of complications.
That brings us to the end of our deep dive into medial thigh lifts.
Yeah.
Hopefully this review has given you a solid foundation for the FRCS exam.
Remember, the key is to understand the principles behind each technique.
Yes.
The potential complications and the post-operative care.
Right.
This will equip you to handle any exam question confidently.
Best of luck with your exam preparation.
Thank you.
And in your future surgical careers.
And to you too.